Good afternoon, everyone. Thank you for joining. We will be starting in just a few minutes. If you are a committee member, if you would put your name in the chat. If you are a committee member who is on the phone, if you would please unmute and let us know that you are here. I think there's just one person on the phone that I can see at the moment. Again, we'll be getting started in just a few minutes. Thank you. Okay, it looks like we've had several more join, including on the phone. If you are a committee member on the phone, if you would unmute yourself and let us know that you are here. Otherwise, committee members, if you would put your name in the chat and we will get started in just a moment. Michael, I'm still counting, but I think I'm a few short for a quorum.
All right, thanks, Sharon. All right, well, Sharon, will you just keep me posted when we do get a quorum? I think we'll go ahead and get started, even if we don't have enough to adopt the minutes yet.
Yeah, I certainly will let you know. Thank you.
All right, thanks. Okay, first item on our agenda today is the selection of a new chair and vice chair for the MAC starting in August. So our bylaws have an appointment in terms of 2-year duration as a vice chair, and then usually progressing to the chair position. And as things have turned out, Jennifer Marchant is not able to fulfill the role of the president for the next year. She's been our vice president for the last 2 years, and I will complete my tenure as chair in the August meeting. So in our August meeting, we will be voting on a new chair and a vice chair. And based on our rotation, we'll have a member representative be the new chair, since I've represented the provider community. And then the new vice chair will be someone representing the provider community. I believe Sharon has reached out to all of the individuals on the MAC who have enough tenure left in their time on the MAC to ask them if they would be interested in being considered or willing to serve in either of those positions. So we just want to make everyone aware that in our August meeting, we will be selecting new chair and vice chair for the MAC committee. Are there any questions on that? Okay, thank you. And Sharon has just mentioned that we do have enough of our MAC membership to constitute a quorum. So let's consider our meeting minutes from our May meeting. So are there any proposed changes to the minutes that were distributed for review? If not, then I'll entertain a motion to approve them.
Move to approve.
Okay, thank you. We have a second.
I will second the motion.
Okay,
To
thank
approve
you.
the minutes.
All right, and then we will proceed with a silent vote. So anyone who is opposed to adopting the meeting minutes, please let us know. If not, we'll consider silence to be a ratification. Okay, thank you. We will consider those meeting minutes approved. Okay, next item on our agenda is the voting on the budget recommendations. As you recall, in our meeting last month, we had several presentations for new funding requests that could be considered in the state fiscal year 2026 budget. That would start a year from July of 2025. And those recommendations will be considered and possibly included in the governor's budget proposal that will be released later this year as the Department of Health and Human Services considers its budget recommendations to have the governor consider.
Yeah.
So we will be voting, or have already voted. Sharon has distributed a ballot for people to rank the 27, 28, I can't remember. There were a number in the high 20s of items requesting additional consideration for funding that the MAC has had a chance to vote on. If you haven't submitted your vote, then please take time now during the meeting to rank your preferred choices, highest preference being 1 and lowest preference being whatever 27 or 28 order is on the tally. And then if you can send those in to Sharon before the end of the meeting, we'll hope to have her tally those up and have results for the end of the meeting for everyone to be aware of. Sharon, do you have any other comments or thoughts you'd like to share on that?
I do not. I do have a couple of committee members who have not voted yet. So like Michael was saying, if you would either get your vote in on RedCap or you can send me an email with your rankings. I will also be following up via email with those that I have not received a vote yet. And if you have any questions, please feel free to reach out to me. Thank you.
Okay. Thank you, Sharon. And that link to the RedCap online voting tool was sent a little over a week ago from Sharon, or close to a week ago if you're looking through your email trying to look at it. Okay, any questions from the committee members on that? Okay. All right, our first agenda item then is employer-sponsored insurance overview. We have Gina Boren from the department to present some information to us. Gina?
Thanks, Michael. Let me just share my screen 1 second, everybody. I am Gina Boren. I am the Assistant Office Director with Office of Eligibility Policy. Rachel Craig reached out to our office and asked for us to do a training on our premium reimbursement programs. So now that we are done unwinding, our members are required to meet the eligibility requirements for our premium reimbursement program. So today I'm going to go over those requirements. I'll take the questions at the end, or feel free to raise your hand if you have any questions and I can get that answered. But let me present right now. We can get started. Guys, everybody can see the screen? Looks like they can.
Yes, we can. Thanks, Gina.
All right, is it big enough? So today I'm going to go over our premium reimbursement programs. So what are the options that our Medicaid recipients have? So there are two options. There are the adult expansion with employer-sponsored insurance and the UP program. So adult expansion is for adults with or without children, and UP is a premium reimbursement program. Let's talk about the requirements for AEM with ESI and UP. So we're going to go over AEM with ESI first. So the member must be eligible for adult expansion. They must meet the citizenship requirements, meet Utah residence requirements, and be between the ages of 19 and 64. The income must be at or below 133% of the federal poverty limit. There is no asset test. And for adults, for parents or parent caretaker relatives who have children in the home, they must meet the minimum essential coverage requirement. So meaning that the children need to either be on Medicaid or CHIP or have health insurance that meets that requirement. So when thinking about adult expansion, so the key to this program is if the individual has access to a qualified health plan, which the criteria is listed here on the screen, or they're already enrolled in a health plan, they will be required to enroll in that health plan if the plan meets a qualified health criteria. So that is really when thinking about adult expansion, the key to the program is access to a qualified health plan. So if they do have a qualified health plan, if the plan does meet that criteria, we can reimburse the employee and or the employee and spouse, but the spouse must also be enrolled in the adult expansion program as well. For the UP requirements, the individual cannot be eligible for Medicaid. They must meet the citizenship requirements as well as Utah residency, be between the ages of 0 to 64, does not have access to Medicare or veterans benefits, and the plan must also be qualified in order to qualify for UP. So the key to UP is access, but not already enrolled. So the member can have access to, if they have access to a qualified health plan, but not enrolled, and they're not eligible for Medicaid, they could potentially be eligible for UP, or they're already enrolled in COBRA or have access to COBRA as well. We will reimburse up to $300 for each for each adult and $180 for each child. Let's talk about the exemptions for adult expansion. So there are some exemptions for the adult expansion program. Verified American Indian or Alaska Natives are not required to enroll. Individuals who are already enrolled in any other type of health insurance that is not their employer-sponsored health plan. So an example of that would be maybe you're on your parents' insurance. You would not be required to enroll in ESI. Optional to enroll, American Indians or Alaska Natives do have the option to enroll as well. The spouse who is eligible for adult expansion but only has access to enroll has a dependent in their spouse's qualified health plan. If an individual chooses not to enroll in their qualified health plan, they can be sanctioned. There will be a disenrollment. So individuals who fail to meet the ESI enrollment requirements may lose eligibility for the program. The ineligibility period is up to 12 months and begins the month following the closure of adult expansion. Reasons an individual will lose adult expansion is if they voluntarily terminate their qualified employer's plan, or they refuse to enroll in their qualified employer-sponsored plan, or fail to verify the employment. There are no exemptions for UP or disenrollment for UP. This slide right here just goes over the process that eligibility workers go through for adult expansion with ESI. If they do approve, the member is approved for adult expansion Medicaid. The member has access to or is enrolled in health insurance through their employer. The DWS caseworker sends the form, the 116M, it's the health insurance information form to confirm if the plan does meet qualified health plan criteria. The DWS caseworker sends notice to enroll in that plan, or if there is a QHP available and not already enrolled. Once enrollment in the plan, or confirmed reimbursement, and the reimbursement will begin. Next up is UP. This is the eligibility process for UP. So member is not eligible for Medicaid. Member has access to health insurance through their employer. DW's caseworker verifies eligibility and sends Form 116 to confirm if available health insurance is a QHP, the qualified health plan. DW's caseworker sends notice to enroll in available health insurance. So once enrollment is confirmed, then we'll begin the reimbursement. For the payment, reimbursements begin the month the member is found eligible or the month the member enrolls in the eligible insurance plan. Reimbursements are sent by check for the upcoming month and as soon as the member is confirmed eligible. Right here, we just have some contact information. If you have some questions about adult expansion with ESI, you can send questions to our esi@utah.gov email. The phone number listed here is to our policy specialist over the adult expansion program, and currently that is Jeff Dart, as well as the fax number. The fax, if you had to send us any documentation, it would go to this fax number listed. And same thing, we have the contact information listed for UP as well. We have up@utah.gov, the phone, as well as the fax. Right here on this slide, I've provided some resources that you can find more information for UP as well as ESI. The adult expansion resources, this is on our medicaid.utah.gov webpage, along with the UP resources. There's an UP brochure. You can also find a copy of our Form 116M, which employers fill out to verify if the plan meets qualified health plan criteria. I did list the Medicaid policy sections for adult expansion with ESI as well as UP if you'd like a little bit more information. These are hyperlinks which will direct you to this information. And any questions that we have about the programs? Yes, Rachel.
So first of all, thank you, because I was the one that requested this and you also spent time with me. So I just want to appreciate, thank you for all the information. Do we know what the current enrollment is, those that are enrolled in the ESI? I know UP I can usually see through the approps process. Or it might be somewhere else, but ESI is kind of hard to find for me.
I don't have the number offhand, but I can gather that and I can email it back. I can send it to you. I have your email address.
Awesome. And then I don't know if this is possible, but if this could be added to the enrollment report, just an ESI section. So basically, I don't know who would be the right person, if it's you or someone else, but really right now, when we look at the enrollment report, we can see a lot of different types of Medicaid. This isn't one that has its own section, so you can see how many people are enrolled. I'm just curious because I don't I just would like to be able to see that, if possible.
Yeah, that's something I can take back and follow back up with you if that's okay, Rachel.
Cool. And then last thing, is there any resource, because what I'm hearing a lot from enrollment assisters on this specifically is that employers are really not doing a great job at filling out the forms, to put it, I guess, kindly. I've heard of enrollment assisters having to drive to places of employment to have managers fill it out. And that's in the case of small businesses. But in case of mid-size or larger businesses, a lot of times HR is either maybe one person in mid-size, or if you're larger or sometimes mid-size, they'll actually outsource HR and to outside of Utah. And sometimes I've heard out of the country, I don't know how true that is, but it creates problems where employers aren't filling out the forms. So people that are subject to the ESI requirement, or they just need to confirm that their insurance isn't, going to qualify for the ESI requirement, they're not able to basically finish their application because of employers not filling out the forms. So I don't know if there's any resource. I know that you guys do trainings for employers, but I mean, that's if they're willing to do it, right? There's no way that you guys can call them yourself, have DWS or someone from DHS call them, because I don't know if they're taking, met their employer, and I don't think employees want to bug them either, because there's like a stigma behind that, right? Like it's weird to go at your employer and say, I need you to fill out this form so I can get on Medicaid because your insurance is too expensive or you don't offer me insurance, if that makes sense. Just like kind of a conundrum for me, and I think for a lot of assisters that are kind of helping people. And that's if someone is using an assister. And honestly, I still think the grand majority of Medicaid applicants are not using assisters as much as we would love them to be able to. It's just the reality right now.
Yeah, that's a great question, Rachel. So the form itself is not required, just the information. So the member can actually have contact DWS and they can attempt to contact the employer if to gather so that, you know, somebody doesn't have to drive over to the place of employment, right, to gather that information. So that's an option for you to consider as well. But yeah, I didn't realize that, you know, you had, you know, individuals going to the place of employment just to get the form filled out. But yes, a worker can attempt to gather that information by phone if that helps, because the form itself isn't needed, just the information in the case.
Okay. Yeah, I mean, I think that would be a good thing to maybe remind some eligibility workers, because I think that most of the assisters are under the impression that the form is required, like the actual form needs to be filled out, and maybe phone calls will help. But I think I'll have to go back and ask them if this would help, because I think they're even having trouble with these like kind of outsourced HR, the people that are supposed to fill out the forms, but they're out of state. And they're not familiar with Utah state law, or it's as familiar as they should be, I think maybe. So I think that might still cause a problem. I'll check back with them and get some information on that, because I know it's been tough, to say the least.
But I will also follow back up with you on that, because we can look at better ways to improve the process if it's still an issue. So
yeah, that would be great.
Yes. So I think that will be helpful. I'll follow back up with you on how we can make that better. Is there anything else? Anybody have any other questions? And Rachel, Brian got your number, it looks like.
Yeah, this is Daryl. I just had a quick question. Is there any requirement that that employers complete a document that is sent by the state? Or can they just say no? Thanks.
Are you referring to any document? I guess, Daryl, are you referring to any document?
Well, I guess Medicaid eligibility documents in particular. You may not know the answer, it may not be the case. It just thought, you know, there probably ought to be an expectation set if you're doing business that you have to cooperate with the state when they're working on a Medicaid application. That's probably like obvious to a lot of people, but to some companies it may not be. So just an idea to throw out there if it's ever a possibility. And I don't know what the enforcement mechanism would be either, but just throwing it out there. Thanks.
Thanks, Daryl. I think there was one other question.
Yeah, it was me, Gina.
Oh, yes, go ahead, Stephanie. Sorry.
Oh, no, it's okay. I was just curious if the majority of the denials of ESI are related to the Hyde Amendment.
Honestly, I could not answer that right now without, you know, researching that a little bit more. But if that's something that you would like me to see, if that's something we can pull together, we can look into that, but it would require a little bit more research on our end for that specific reason that it's being denied for not meeting that. So
I would be curious about that, because I feel like I know that in conversations that like Rachel had with me about all of this over the last several months, I think some of the gut instinct of like, you know, people on the ground just like dealing with people who they would think would be eligible, but then they end up not being, like, it would make sense that like one of the reasons the numbers were so low is because of like, it would be if it was related to the Hyde Amendment. Otherwise, it seems like the numbers of VSI should be higher, just from like I think that's just kind of what I'm curious about. Like, it would make sense if that was the reason, but if that's not the reason, then I would not fully understand why we don't see higher numbers in ESI.
Yeah, that's something we can take back, and I can help coordinate that with DWS. But yeah, that's a great question. And I can follow back with you. I have to follow back up with Rachel, but yes, I can do that. Is there anything else? Does anybody else have any other questions before we move on?
Sounds like that's good. Thank you, Gina, so much for your presentation and your willingness to circle back on some of these items that the committee has some questions on. That'll be very helpful. Okay, next we have Brian Roach on the unwinding closeout report. Brian?
Thank you, Michael. Let me present my screen. All right, thank you for allowing me to present on the unwinding closeout. The unwinding did end in the state of Utah on April 30th, and we're just here today to talk about some key events and future steps that the HHS and DWS are going to undertake that last beyond unwinding. Just a background, I know this is a knowledgeable group, but just for the background, the continuous eligibility requirement was introduced with the COVID-19 pandemic. And then the Consolidated Appropriation Act established that April 1st, 2023 was the beginning of that unwinding phase. For Utah, we did prepare long in advance, creating a distribution plan. We were one of the first states to create a dashboard. We were prepared prior to Consolidated Appropriation Act, and then it is some certainty about the beginning date. We created some additional enhancements along the way, and then we are now in the post-unwinding phase. Enrollment has reduced through the process. From the high at April 2023, before unwinding closures began, we were at 536,000 members, and we are currently at about 345,000 members. For context, prior to the continuous eligibility requirement, the Medicaid enrollment was around 317,000. Obviously, there were changes along the way, including adult expansion. There continue to be some policy changes today that affect enrollment, like postpartum coverage up to 12 months, 12 months continuous eligibility for children. So all factors kind of meld together to affect enrollment, and it will continue to vary as we go. But we're at about 345,000 at this stage. A reminder of our goal going into unwinding was providing a smooth member transition through clear communication, data transparency, and robust planning. There was a substantial effort conducted by both our department and DWS, reviewing 500,000 members, keeping average days to decision around 12 days. We conducted multiple EREP eligibility system fixes and improvements along the way, responded and submitted multiple baseline and monthly reports to CMS that are continuing through this day, updating as we got further guidance from CMS that also continues through this day and is starting to create our next phase, which we'll talk about some of the final rules that are being developed by CMS. We had 13 waivers and other strategies. That's not 13 E14 waivers, but it's a mixture among E14 waivers and other strategies. There were a total of 13. We had more than 40 outreach events. It was kind of heartening to myself, meeting recently with our eligibility policy team, and knowing that every single one of our eligibility policy staff have attended an outreach event. And then more recently, creating communication tools in 13 languages and continuing to update our dashboard along the way. Through unwinding, we did have a couple of course corrections, and a big one was precipitated by a CMS letter that was sent to Utah as well as all states. But for Utah specifically, CMS did express two areas of concern. That was call center operations and our procedural terminations. For call center operations, we addressed that through ex parte automation. We have spoken about that a lot because that is something we're fairly proud about. Many states we've heard when attempting to do similar things have taken 2 to 3 years, and we were able to implement it in 2 to 3 months. One of the big benefits of that is freeing up additional time for workers to work forms, for them to man the phone lines, to do all of those things that rather than focusing on stuff that it's do. We also created customer video helps along the way as well that were posted to our website. We also had a procedural termination rate expressed as an area of concern by CMS. We did attempt to move the needle a little bit by pursuing additional flexibility. That in particular was using our managed care organizations to assist us both when a pre-populated renewal form was sent, and then also after closure, for reminding members that it's not too late, they can re-enroll in the program, and trying to use our managed care organizations to help us with that communication. As well as additional system and training corrections that we did both in the EREP system, in my case, that aim to improve the renewal experience along the way. We also did receive and are still engaged in 2 unwinding audits, one conducted by the Federal Office of Inspector General, or OIG, and then the Office of Civil Rights. Those continue, but we are engaged with them to work through questions and audits along the way. Along the way, we did conduct, or we did create or engage in multiple waivers and other strategies to support members. We adopted 5 strategies to support enrollees with renewal form submissions. Those are primarily using our managed care entities. 4 strategies to increase ex parte renewal rates. Those are the ability to automatically renew if a member had no income and no data returned through electronic sources, the ability to renew them automatically, as well as our asset verification system being able to renew if there was not a timely response from the asset verification system. Those were intended primarily to help the most vulnerable individuals with homelessness, and that's why we adopted them. 2 strategies to update contact information using both our managed care entities and the National Change of Address database, and then as well 1 strategy to increase member timeframes for fair hearings. There was another one with our ex parte adoption that CMS recognized as a mitigation plan. As we adopted ex parte, we continued to pursue, as we entered the unwinding phase, we continued to attempt ex parte even after a pre-populated renewal form was sent. And that was also considered to be a strategy adopted by Utah. So as we continue beyond the unwinding phase, it has created or reinforced some of our culture of continuous quality improvement. We are, as we've talked about before, continuing through next phases of the ex parte automation. We did implement automated ex parte in a fairly conservative manner. There were some pieces that if the system with not enough certainty could do it through the system, it would take it to a manual effort by the worker. And we're continuing to see what else we can have the system automate and free up additional staff time and make continue the improvement there. Making data enhancements and data-driven decisions, as we've talked about it internally, this unwinding experience has created new terminology for us, new indicators for us that really do help us for the onset. So one thing is, prior to unwinding, I don't think any of us could tell you what our ex parte rate was, for example, or procedural termination rate. These are now terminologies that we can measure ourselves again and measure the effort, the outcomes of quality improvement initiatives that we undertake. And then also improving member communications and outreach and member support. We have talked in this forum a few times about the notice improvement committee that is being done to look at the member notices, as well as drafting new guides for members that can guide them through the process. This is, for example, what does the eligibility renewal look like? These are your resources along the way. We're continuing to develop those resources, as well as improving something like texting. We've identified that as a certain improvement project that we can undertake with DWF to improve both the quality of the message and the quantity of messages going out that we're looking to undertake with DWS. So that's the road ahead for Utah. And at this stage, I'd be open to any questions. Destiny, go ahead.
Hey, Brian. Thank you for presenting that. I have a number of questions / suggestions for maybe what, like, at least I would be like more interested in understanding. I feel like, you know, this has been for members a pretty horrible experience. As many of you may remember, we discussed last year an individual who passed away due to a preventable condition and all of the challenges that he faced trying to access support. We have, through outreach events that myself and others have helped Medicaid with and partnered Medicaid with, I mean, the stories have been like really awful, and people's lives have been negatively impacted. Early on last summer, when, you know, the Medicaid Advisory Committee, we put together a list of recommendations that we wanted you all to work on over the fall, after the summer, of just like really bad data of how many people were dropping off. We know that the plan changed because of whatever political chaos influenced the Medicaid plan from changing. I mean, it's been horrible. And there are eligible people that were disenrolled. There are eligible people who are still disenrolled. And I appreciate that it's been really challenging for both agencies, but it's not been like, we don't look good. We're one of the worst states in the country in this area. And I apologize for highlighting such negative information, but at the end of the day, like, it's not an area where we are the best ran state. And I feel like a part of what I had hoped that this report would do would be to really address some of the specifics and some of the underlying causes. And, you know, it gave an opportunity for the agencies to be able to collaborate together to really figure out like what is going on and what is our goal. Like, is our goal to keep people off Medicaid, or is our goal to enroll every eligible individual? And getting aligned on that. And I feel like so often the frustration, again, I speak as a person that is like, has experienced this myself, but has spent hours and hours of my time, like, I don't even like so much time trying to help individuals in the community. And I feel like the amount of like, it's really frustrating. And I'm very grateful to the team at DHHS that has been really helpful. Your eligibility team has been so incredibly helpful. And I appreciate the times when I have received support from DWS as well. But at the end of the day, like helping one person at a time whenever we need systemic change and operationalize change to like actually align ourselves with the goal of having the best ran state, et cetera, et cetera. I mean, I wanted to know about disparities demographically. We had reports on that, I believe 2 or 3 times in the, in this process, but like there's no conclusion of that. Knowing about whether or not there was a higher proportion, for example, of Pacific Islanders that were kicked off as it had showed in some of the previous reports. I mean, seeing some of that data is really helpful, knowing how many people with disabilities through ABD program, spin down, et cetera, like we're disenrolled. I mean, some of that is really helpful for us to see. And so having some more data on that, and then really some specifics about some of these gaps of, okay, we learned that because of like PRISM at the same time, like we found that like there were technical disenrollments that impacted X 100,000 people. Like some of the just like, what do we know? Like what are like just like surfacing some of that so that we as the public, as people that are trying to contribute to this committee can understand like what we actually know about what has transpired over the last 12 to 18 months. I feel like, if you think about like the text, the thing you said about text, I mean, like where are we actually at with that? Like how much was that utilized? Like, was it utilized at all when it comes to the unwinding? Like, what do those texts look like? What is the next step? Like, it just feels like I appreciate it, Brian, but it was like a little bit vague if I'm being honest. And maybe that's like all that you all feel like you need to report to this committee. And I can appreciate that I might be asking for more than you feel like you should or can like offer, but I just feel really frustrated that after the amount of it's like been really hard for people. And I feel like knowing those stories and knowing those individuals and what they have been through and how much suffering, frankly, has happened. Like, I don't know, like if we're one of the worst states in the country now with like how many kids have been kicked off of Medicaid and CHIP, like, I just feel like it deserves like a much more like a deeper analysis. And I just like, and I'm not like trying to shove this into you, Brian. I just like, that is like a part of this committee. And I just feel like, what are we all doing? Like, if we're not going to get like a deeper analysis, because I understand the legislative committees don't seem to spend time or effort or any concern on this, but like, this is like really important to some of us. And we show up in every single way we can to show up how much we care. And like having more information from y'all is like how we can be better advocates, how we can manage our own expectations about like, what is the actual policies of this state? Like, do we want eligible people enrolled or not? And I just feel like seeing that in some of the like deeper analysis is really critical to that. And I mean, I have like suggestions for like things that I think would make a more comprehensive report, but like I don't know, like we're not the political committees that like aren't interested in a deep dive. I feel like this committee is actually interested in a much more deeper, comprehensive dive. Maybe it's just me and nobody else cares, but I just feel like, I don't know, this is like the hardest thing that has happened to a lot of members. Like this is like the most stressful part of their life in the last year for a number of people that I've talked to. And I just feel like that, it deserves like a deeper analysis so that we can figure out how to actually improve the system, because it's like not been great. We do a lot of things well in Utah and this is not one of them. And I feel like we need to be honest about it and like actually figure it out. And anyway, so I appreciate it. And also I just feel like that was like, we need something deeper.
Yeah, I appreciate that, Stephanie. And I think what I wanted to get across, and I can reiterate, is this doesn't really, end our participation in bringing additional data. Like unwinding doesn't end the process of quality improvement. We do know that there are efforts that we can make to improve the process for members. we do have the goal that every eligible member is able to enroll. I mean, that is something you mentioned as like needing some certainty. That is absolutely a goal of ours, that eligible members are able to enroll, period. But yeah, I mean, additional things on disparities. I know we've committed to bring some additional disparity analysis. That was something that we produced through unwinding process. And yeah, that is something that we are planning to bring back to this body at some point. It is a little bit harder to identify like starting and ending points, but we can look at creating another closure report that is based on certain demographics, if that is of interest. Texting, yeah, so there's a little bit more specific that up until this point, for example, texting has relied on knowledge of the member's mobile carrier, for example. So, well, it's still the case today. So whether they're on AT&T or Verizon or whatever has been a requirement. We're working with DWS to first remove that barrier, that regardless of the carrier that we're able to conduct texting, that will require a change request. So we need DWS involved in that. And then what we want to do, some of the initiatives, this have to be prioritized with our other work, as well. The next agenda item in this setting is to talk about eligibility final rules. So there's a lot of, I think, improvement projects that are built into that, but along with that are some, so fitting that priority along with texting would be another thing, is changing it to an opt-out rather than an opt-in provision. We make it tied together with enrollment in electronic or paperless enrollment for renewal notices. We're looking at ways to change that from opting in to opting out, so more people automatically get enrolled, and then changing the message a little bit. Everything has to be prioritized, and there are improvement projects that we're working on. But yes, I do hear you that additional data would be helpful, and we will bring additional data through, but it is helpful to hear this body kind of say what is important.
Thank you, Brian. And I think somebody else had their hand raised, but I guess I would just like appreciate all of that. And then one of the things that I know has come up and that I thought was going to be included in the report that has come up multiple times in the last 12 months has been like a breakdown of those procedural denials, like getting deeper into some of that. And like, is it paperwork, which verification is like which ones are being held up the most? I mean, again, some of this is just kind of like surfaced over time. And I think sometimes it gets kicked down the road, and I totally get that y'all have a lot on your plate. And frankly, I don't always know which should be which agency. Like we do pay the other agency to do a lot of eligibility. So maybe they should also contribute to like getting some of this done. So it's not all on you and your staff, but I just feel like having some of that, like surface of like how, like, what did they actually do to reduce the call wait time? And like, if it is reduced, what is like the formula behind that? I don't know. Some of it's just like, let's like figure out like maybe there are some things that are working, or like you guys did some ex parte stuff, but you also didn't do some, like how many of what number you could possibly do, like some of it. So it's just like, we did this many, we could have done these other ones. We didn't do these other ones. Here's why, or just things that, again, I just feel like this really, really matters. And it's worth like literally, like, in my opinion, an entire MAC committee dedicated to just like going through like lessons learned, because I feel like it matters that much. We're in federal audits. Like, what are the details of the federal audits? How can we like stay informed on some of this stuff? Because again, I just feel like that's something that we should all be able to have access to as well. But I appreciate the work y'all did put into it. And I recognize there's like limitations. But just like, I don't know. I guess that's also just like, do we need to like, as advocates, like ask the legislature to like make sure that there's like enough staff to like help with like quality improvement, because I feel like that is also something that would be helpful for us to know, so that we can make sure that there's enough staff capacity to like invest in quality improvement and to actually like do that work in both agencies, right? And so I guess maybe that's also just like, something that, I don't know, sometimes it would be helpful if we were able to know, so that we can like understand like the reason this is not as deep is because like you all are super maxed out. And maybe that's something that we need to know, so that we can prioritize whether we ask the legislature to fund you guys to have better quality, just to have staff time, so you're not like leading to burnout. But anyway, I appreciate that. But I do obviously have a lot of other things I wish were included in this, but I appreciate what you all were able to do, and would appreciate any additional information on the disparities and the quality improvement details that you all are working through. It would be helpful for me to be able to manage members' expectations as well, especially at these community events where we're trying to connect you all to people in the community, like how many requests at these events like are actually implemented versus just like how much are people just like sharing things that like really suck. But then like at the end of the day, like if there isn't like, are the changes happening later anyway? So I just feel like some of that is kind of just like where I'm at. And again, I do feel like it's not just for your agency that's responsible. Frankly, a lot of the issues that I hear about are due to like eligibility workers having some errors, which I appreciate that they've been really, I mean, we all know that they have a lot on their plate, but that is like also a part of it. So maybe it's like some kind of agreement between the agencies on who's going to like share about which quality improvement strategies or what we can expect. But just want to make sure that we don't just, it's just been a really hard year for the members and for people that serve the members on the ground. So.
Yeah, I appreciate that, Stephanie. I know it takes a lot to speak up, and I really do appreciate it. We will continue to be reporting to this body about enrollment activities, and that will last into the future. So, but the procedural termination, I know you have mentioned that before about like which forms or verification, if it's after a verification form has been sent, it is a bit trickier to parse that out. And we do have a priority list for reporting that it is on there, but we will try to bring that back as soon as we can. It's still relevant information beyond unwinding. So thank you for your questions and feedback.
All right. Thank you, Brian, and thank you, Stephanie, for the perspective on the report. Next, we have Michelle Smith to present on eligibility and enrollment update, and then on the CMS rules for the eligibility determination, enrollment, and renewal process summary and implementation. So let's go to you, Michelle.
All right. Hi, Michael. Thank you. Hi, everyone. I'm going to go over our eligibility enrollment report to start off. For those of you who are not familiar with this report, it's actually available on our website. I'll just go ahead and drop the link into the chat so you guys can all access that on your own and go ahead and dive into any area that you want to. But I'm just going to highlight a few things on here. So I'm on the persons tab here at the top. Our current enrollment count for the month of May is 339,682 individuals. If you look here, there's two tabs. There's an interactive graph, which we're looking at right now. And then there's a data table tab that goes into kind of more program specific. If you look at this, obviously with unwinding each month, we've seen a decline in each of the Medicaid programs. It has started to slow. And if you look specifically, there's two programs where there's been an increase. So for pregnant women, month of April showed 12,077 and then went up to 12,321 for the month of May. And then also for the CHIP program from 11,797 to 11,818. I would attribute the pregnant women increase with the 12-month extended postpartum that went into effect this year. And then obviously CHIP has been increasing all along since we are unwinding and moving children who are no longer eligible for Medicaid onto the CHIP program if they are eligible. So I just kind of wanted to highlight those two things. Another program that I think is worth sharing. Some of you follow this very closely and get excited every week when this gets updated. We do update the enrollment on this every week, but on our CHIP website, again, I will go ahead and, for those of you not familiar that want to follow, we have been updating weekly our state CHIP program enrollment numbers. And if you look at this week, our current count is at 1,240 children. We have the 2,000 children cap for this program. So this program, open enrollment, started January 1, and it's been increasing every week, which is great. We love to see, and hopefully this is helpful for you all. So that is the enrollment. So I don't know if you all want me to pause there, if you have any questions, or so I'll kind of pause for a second before I go on to the final rule summary. Okay, so not seeing any questions, I'll go ahead and move on. So all of you should have received the summary that Sharon emailed out. So you should have that in front of you, hopefully. And some of you may have had time to look at it. Some of you may have not. But just to remind you all, a couple of years ago, there was a proposed rule for Medicaid and CHIP eligibility enrollment and renewal that came out September 7th, 2022. I provided a very detailed summary to this group 2 years ago on this proposed rule, what those changes we were anticipating, and looking for any comments that we could get back to CMS at that time. On September 18th of this last year, so 2023, CMS released first part final rule on this proposed rule, which was mainly around the Medicare Savings Program provisions in the proposed rule. And then later, March of this year, they released the second and final version, final report, or final rule, excuse me, on the proposed rule, which include the remaining provisions. So down here, the way I've kind of put this together, it was really difficult because there's a lot of information in this rule, but a lot of really great things coming our way. So what I try to do is just kind of keep somewhat of the same format that I did on the proposed rule, but CMS actually put together this really great chart that I kind of copied a little bit on compliance timeframes. Each of these provisions are clumped into 7 different compliance timeframes. So I try to highlight this here for you all. So in this gray tab, you'll see I have it broken down by different compliance dates. And then I list out the provision individually, what the provision is, a little bit of a small summary of that provision, and then what the impact to Utah will be. There are some of these that have no impact to Utah. They're either items that we're already doing and compliant with, or they're optional provisions, and we have not yet taken up those options and might not take up those options. So I've listed that out as well under the impact. For the sake of time, I won't go through word for word into each of these provisions, but I do want to highlight some. But I also want to share with you this great resource for those of you who are familiar with state health and value strategies, SHVS. They actually put together this really great slide deck that gives some really good details on each of these provisions. So for those of you interested, please feel free to take a look at that. Can give some more information. that you would like, but I'm just going to go ahead and start highlighting a few of these. I also have Melissa Presley. She's obviously in this meeting today. So Melissa, please feel free to chime in and add or correct anything that I might miss. So the first thing I want to highlight, obviously, this first area is around compliance dates of June of 2024, which is the month that we are currently in. So we are actively working with DWS on the provisions that we are required to be implementing. The first two, this first one is optional, but the first one we are already in compliance with. We do not limit the number of reasonable opportunity periods. Number 2 and 3 are items that we are actively working on. We will be applying a reasonable compatibility threshold for assets now based off this provision. Currently, with the passing of ACA, we have a reasonable compatibility standard with income. This will now apply to resources. This third one is just improving transitions between our programs. So when someone transitions between Medicaid programs or CHIP or the marketplace, it's just making improvements on those transitions and ensuring that there's no gap in coverage before a final decision is made. Moving down, another one I want to highlight is number 6, is removing access barriers for children. So premium lockouts, you all heard, I believe in the last MAC, that we are ending CHIP premiums effective July 1st. So this no longer impacts us. Also waiting periods being eliminated. We do have this in place today. So if someone voluntarily ends their health insurance, they have a 90-day waiting period before we can consider CHIP for them. And then this eliminates annual and lifetime limits for benefits. Currently today, we have limits around dental and orthodontia. So we will be working towards removing those annual limits. The compliance date on that is June of 2025. So that will be coming next year. Another provision that I'd like to highlight is removing the requirement to apply for other benefits as a condition of eligibility. That's a big one. I think that will be extremely helpful for individuals. We will still be educating individuals on other benefits that they might be eligible for and qualify for, but it will no longer be contingent to apply for these to be looked at for eligibility. I think those are the biggest ones I'd like to highlight, and I will end with the last two, 15 and 16, where we talk about acting on changes in circumstances and meet new timeliness requirements at application at renewal and upon changes in circumstances. These will be a big change for our state and will be a bit tricky in terms of coordinating with our other programs and the timeframes. Since we are integrated with SNAP, financial, and childcare, they have their own program standards. And so this is actually something we've put a question out to CMS to ask for resources and guidance and more helps around integrated states and how to best implement these two provisions. So I will pause there and just ask if anybody has any questions, comments, or feedback. Just keep in mind, this still is fairly new for us. We are deeply involved in still researching, participating in CMS calls where they are continuing to go over these provisions and providing more guidance to us. So I may not be able to answer all of your questions, but if I can't, I will take those back and hopefully get answers to those. So, any questions? Okay, quiet group, Michael. Okay.
Well, thank you, Michelle. It's a nice presentation, a lot of material to go through, and I'm sure as more time comes out and you get into the implementation, we'll have more information that you can share with us in terms of what it actually means for people as the process gets implemented and it moves from the theoretical to the real. So thank you for giving us an overview. We appreciate the presentation, Michelle.
Thank you.
Okay, next we have the director's report from Jennifer Strohecker.
So Michael, unfortunately, Jennifer's in Washington, D.C. and was trying to make the call, but she couldn't. So she asked me to cover for her. So I apologize about the last minute change.
Well, we will be just happy to have you. That's not such a disappointment as you might think. And Washington, D.C. does suck the best out of all of us at different points. So we will give her a mulligan on that and look forward to your presentation. Thank you.
Certainly. Thanks, Michael. Okay, so first off, I'd like to talk about what's happening with the 1115 waiver and justice involved items. So the health related social needs waiver, we are planning on submitting that to CMS next week. So it's the culmination of a lot of hard work and we're excited to get that out. In addition, the justice addendum has been submitted to CMS and we are expecting an approval on that soon. So I'd like to switch gears a little bit and talk a little bit about the Change Healthcare cybersecurity incident and how it affected the pharmacy fee-for-service program. As of yesterday, our preferred drug list came back online and all historic drug files from February 2024 forward have been loaded through the point of sale system. We've put out frequently asked questions to pharmacy providers and are alerting them of these changes. Next, I'd like to talk about the pharmacy point of sale RFP. As you know, we've put out an RFP for a new point of sale vendor. We are in the process of evaluating the bidders and are hopeful to have an award issued very soon on that. Next, I'll talk about CHIP premium changes. So on October 27th, CMS announced that the Consolidated Appropriations Act prohibits terminating CHIP coverage for non-payment of premiums during the 12-month continuous eligibility period. This was contradictory to the practices within the state of Utah. Effective January 1st, we continued to charge premiums, but would keep cases from closing if families did not pay, based on this guidance from the federal government. We are in the process of updating our policy, state plan, and administrative rules so that premiums will be eliminated altogether. We're planning on making this effective July 1st, 2024. Some copays and deductibles will increase to compensate for the loss of premiums, but families will still not pay any more than 5% of their household income toward the cost of care. These changes will also be made for the state CHIP program so that it corresponds with the CHIP program. DHHS, the department, sent out a letter on May 29th notifying individuals of these changes. Next, I'd like to talk about supported living coverage for fee-for-service. Beginning on July 1st, qualified Medicaid enrolled providers may report supported living services as defined in the Rehabilitative Mental Health and Substance Use Disorder Services Provider Manual using code H2016, which is Comprehensive Community Support Services per diem. Chapter 2-20, Supportive Living, has been added to the Rehabilitative Mental Health and Substance Use Disorder Services Provider Manual, outlining this new policy. Finally, I'd like to touch on the quality contract that we've been working on for our managed care core set reporting. The contract has been awarded to OnPoint to manage that, and we will start that on January 2025. We're in the process of still finalizing the contract. So any questions about those items that I've presented thus far?
Doesn't look like we have any questions, but I guess just comment going back to the Change Healthcare initiative. I don't know that I've heard the department publicly recognize the ACOs who stepped in and helped pay for so many of those pharmaceutical prescriptions being filled. But I think maybe just an acknowledgement that when Change Healthcare was unable to cover the prescriptions, that your contracted health plans, the ACOs, stepped in and actually paid those claims on behalf of the department and Change Healthcare. and just raise some visibility to some of the links the department went to use some of its contracted partners in solving or at least minimizing the impact in that particular situation.
No, you're absolutely correct, Michael, and we are very appreciative of our partners for helping out in that time of need when we were struggling just to keep basic coverage going for members. So yes, I agree. That was fantastic and wonderful of the ACOs to help out in that capacity. So thank you for making that statement and making the MAC aware of that. So at this time, I'd like to turn it over to Joseph to talk about the HCBS and MAC changes.
Thanks, Eric.
Sorry, Joe.
Yeah, I'll bring up a window here quickly and I'll drop a link in chat. Let's see. This way you can follow along as well, or perhaps advance ahead if you are interested. And perhaps first to start with, my name's Joseph Ambernack. I'm the Long-Term Services and Supports Director. It's been a minute since I've addressed the MAC, so there may be a few faces or individuals who may not know who I am. And our office, just a quick overview, provides oversight to the state's 9 home and community-based services waiver programs. We operate 3 of those waivers internally, and then also have our resident assessment group who provides level of care reviews for nursing home and intermediate care facility participants, our waiver quality assurance team, and also include our housing services now, which is a recent development that you're aware of in the last few years. But it's good to be here today. Thank you for allowing me some time on the agenda to talk through what's the Ensuring Access to Medicaid Services final rule. You'll hear me refer to it throughout as the access rule. Eric mentioned the HCBS access rule. There's some terminology there that we'll try to clarify as we go throughout, because there is also a partner rule that we'll also be discussing with you today. But the access rule has several objectives within it. Several of them are items to include are to ensure that high quality services are available to individuals who are enrolled in our programs, that the Medicaid agency better monitor the outcomes and the participant experience in the receipt of services. CMS's efforts as well to be more consistent in monitoring approaches across all of their authorities. An effort to increase transparency and accountability throughout, which includes standardization of data and monitoring, promotion of beneficiary engagement to improve holistic access to care, and again, mentioning that it's a complementary rule to something that Greg Trollin will be speaking about in just a moment. 3 general areas that the access rule does cover, and sorry, I'll scroll down a little bit below, are the Medicaid Advisory Committee and the Beneficiary Advisory Council. Some changes and updates to home and community-based services requirements, and then some general fee-for-service requirements that will extend across several authorities. I'd encourage you as well to take a look at the summary that I've shared. CMS has done an excellent job of this overview. And at the bottom of the page that I'll also link to at the conclusion is a timetable of different implementation timeframes. This regulation has provisions. Some of them will be within a 12-month span, while others phase in across the next 6 to 8 years. So it will be changing a number of things for us in how we operate a few of our programs. So I'll start with the now what will be changed to the Medicaid Advisory Committee and then the Beneficiary Advisory Council. So the regulation does include a renaming formally of the committee, and then better defines a range of issues in which the committee may advise the state. As mentioned, it requires the state to establish a Beneficiary Advisory Council, which does come with some of the feedback that CMS has received nationally, was that individuals or people who may be representing Medicaid participants can find some of the existing committees and infrastructure intimidating when sharing their feedback. And this is also complementary to what we've been trying to do here in Utah as well, to elevate the voice of beneficiaries within our programs, and it's something that we strongly support as well. The rule also covers pieces, it gets into specifics such as the meeting frequency, ensuring that materials are publicly available as far as agendas, the recording of meeting minutes, etc. Ensuring that individuals have public comment opportunities, and that the state provides support staff for both the committee and the council. So it gets a little bit more into the weeds as far as, again, structuring very specific items that the state will need to ensure. Many of those pieces, as mentioned, are things we're doing today, and we'll be providing a more in-depth summary of this at an upcoming Medical Care Advisory Committee meeting as we proceed. Sharon has been assisting in a lot of that analysis, and we'll have more for you in the upcoming weeks and months.
And Joseph, let me just.
Yes.
When does this part of the administrative rule take effect?
This portion is within the first 12 months as far as the alterations to the Medicaid Advisory Committee and then the Beneficiary Advisory Council. There are several milestones we'll need to hit within the first year.
All right, but just so for members of the MAC now to be aware that we'll be seeing changes impacting our current structure over the next 12 months. Great.
Absolutely. You bet. Right, making sure I don't scroll too far. On the home and community-based services side, the rule outlines some general system improvement expectations. For those that are aware of the home and community-based settings rule that was passed in 2014, there were a number of expectations centered around person-centered care planning. This rule, the access rule, now changes or includes expectations that CMS has in how the state provides oversight to that work. So it includes some additional requirements, some performance monitoring that the state Medicaid agency will need to do or assure as part of its work in the oversight of the waiver programs. There's also a number of expectations in how the state manages its critical incident pathways, which includes everything from an initial definition of the types of incidents that a state must investigate, things like abuse, neglect, and exploitation, unexpected deaths and hospitalization, etc. How that data is collected and managed, and then the expectations on how that data is analyzed to see if there are any trends that may exist within programs and providers. So it's a bullet point on this list. Just know that the regulation goes much more in depth perhaps than the summary does here. The rule also outlines a grievance system that must exist for items that don't necessarily arise or arise to a fair hearing or an appeal situation for members. So it could be just concerns with care delivery being received, providers with significant issues with meeting appointment frequencies, for example, if they are no showing for a number of visits, and just generally how members can provide information to the Medicaid agency with issues that they are experiencing. Certainly with a lot of conversation, and you heard it during the public comment received in the last couple of months, that reimbursement rates consistently are a conversation topic. The rule is very specific surrounding, in particular, homemaking, personal care, habilitation services, and services utilizing home health aides. There are requirements for us both in the short term to find a method in which to collect data from our providers on how much of the rate that Medicaid pays is ultimately reflected in direct service care, salary, and benefits. And then a requirement that will take place in a few years to ensure that at least 80% of the rate paid can be reflected in that direct care compensation. So it's kind of twofold, where we need to we're given time to create the structure for how to collect the data, and then in a few years' time, a mandate that again, at least 80% of that rate be reflected in their compensation. See, I'll move down a little bit here. More transparency is also expected for how the state displays information about waiting list for programs, as well as the time frames for the receipt of those direct care services that we just mentioned. So for example, in the waiver programs, a person-centered care plan is constructed at least once a year, If that care plan does include services, again, such as homemaking, personal care, habilitation, we are also required to then report out from the time of authorization, how quickly does that, or is that individual able to access those services? That will be an item that we are required to report moving forward. In addition to just general transparency surrounding the reporting of quality metrics, performance metrics, and general compliance. Many of those reports are public facing today or can be found publicly, but they're often in a format that isn't very helpful or easily understood unless you have a lot of intimate nature or knowledge of our programs. So again, making information more accessible, making sure the agency is more transparent in that work. And then lastly, touching on a handful of items that pertain to the waivers, as well as all of the programs that do participate in fee-for-service. But the access rule covers expectations about the publication of fee schedules, as well as comparing very specific rates to the Medicare equivalent. So if it's percentage based, where we're still working through to receive additional guidance there. And there's also a provision for what many are calling the interested parties work group. So separate from both the Medicaid Advisory Committee, the Beneficiary Advisory Council, there's also an acknowledgement that the direct care worker experience is something that the Medicaid agencies, or many of them throughout the country, does not have direct exposure to. We often take very good feedback from the agencies and providers that we work with, but not necessarily a general understanding of how things may be operating from the worker perspective, which is kind of a unique way to solicit information. Again, salaries and benefits we know as a massive consideration that continues to be reflected, but there are elements that we could be missing in that expansion of the direct care workforce, or to understand what makes people interested in entering that realm. The access rule does require, again, some specific ways that we can solicit and hear from those voices so that we can better understand that as well. And just a general piece on where we are today, where the rule was just published a few months ago. But we are convening work groups with our partners at the Division of Services for People with Disabilities and the Division of Aging and Adult Services, who work with us very regularly on many of these programs, and trying to figure out where each of us are in various requirements of the access rule. A quick example, but the DSPD, the Division of Services for People with Disabilities, they've been doing participant experience surveys for well over a decade and have great trending data and information there on the majority of their programs. We are lagging behind on a few of our other waivers and programs as well. So the ability for us to maybe learn some best practices from each other, as well as just understand where we are as we're proceeding through what will be, again, a 6 to 8 year implementation, depending on the various regulatory requirements. We're also working with our partners at CMS for a lot of the sub-regulatory guidance that's going to be needed. The regulation or the rule itself is general in many situations, and we'll need to learn those specifics so that we can work with our community partners. A good example is the cost reporting, or the data that we will need from our homemaker personal care providers. What do those reports need to look like? What's included, what's excluded, and how do we provide that analysis back to CMS? So again, we're working with them to receive that guidance, and as we kind of hit different noteworthy milestones, we'll be sure to bring those back to the committee here, or as you're interested in hearing updates from us, we're happy to share the work as we're going. And as Michael mentioned, well, particularly with the items in the short term that will be affecting the Medical Care Advisory Committee, we'll be sure to bring those back as we're implementing those changes. And I'll just quickly, the link to this chart that I'm about to show is available at the bottom of this page, but again, provides a very good summary of the timetable associated with each of the provisions that are found with the rule, and being able to kind of see it at a glance, where again, there are a lot of different provisions. It's nice to have that summary available at times. I will turn the time over to Greg Trollen to speak next again about the companion rule, but wanted to pause to see if there are any additional questions that you might have for me before doing so. Yeah, I can drop that again for you here, Kaylee. There you go. And certainly as you have questions, I'll leave my email address here for you too. Please feel free to reach out anytime. You're welcome to ask any questions that way outside of the meeting if you have any follow-up for me.
All right, thank you, Joseph. We appreciate you running through that. Again, a lot of material to be digested and implemented over the coming years, but just want everyone on the MAC specifically to understand how that will be changing our format and approach in a certain number of ways, and we'll get some more details on that as well. So thank you. All right, Greg, managed care.
All right. Yeah, I'm going to pull this up real quick. Okay, so what I'm going to be presenting is complementary to what Joseph just shared. Let me know when this pops up. And again, I'm going to...
Still hasn't came up, Greg. Do you want me to try to present on my end?
Yeah, it's the... All right, let me just try this over. I'm sure it's because I have multiple windows open.
Okay, so I just got it up, Greg.
Okay.
This is the document you wanted to present, correct?
Well, it definitely provides us with an overview. I'm going to drop a different link into the chat. And this just is basically, it's the Medicaid and CHIP Managed Care Access Finance Quality Final Rule. So Joseph was just going over what we're calling the access rule. This here is complementary to that and essentially is a high-level overview related to the access finance and quality rule. And specifically in this document, what you'll find is 7 key elements that are the focus of this rule. The first one has to do with strengthening standards for timely access to care and for states' requirements to monitor through independent contractors related to conducting annual audits and secret shopper surveys of members' experience with these access standards. Also to engage in enrollee surveys. And specifically, if you look at that first category there, the standards are that for primary care adults and pediatrics that appointment wait times would not exceed 15 business days. And in addition to that, that applies to also GYN services. And then for behavioral health, mental health, and substance use disorder services, that wait times should not extend beyond 10 business days for an appointment. It also allows for states to develop specific appointment wait times for other selected state services. The second category has to do with state-directed payments. And for those of you that aren't familiar with state-directed payments are a mechanism by which states allow for additional funding under certain circumstances to organizations or providers in order to specifically address and improve access to and quality of care for Medicaid members. And so this particular area focuses on reducing regulatory aspects related to state-directed payments, as well as certain quality reporting requirements. It also is designed to really provide some additional clarification around how state-directed payments are calculated and implemented. Next item has to do with medical loss ratio. So for those of you who aren't familiar with this term, a medical loss ratio is a stipulated percentage that says of every dollar spent on medical care, a certain percentage of that dollar has to be spent on medical services. And CMS requires that when states develop a specific target for MLR, that a state's MLR, or I should say a state's or a managed care MLR, can be no less than 85%, which means 85% of every dollar has to be spent on medical services. So the medical loss ratio provides some additional stipulations as well as reporting requirements and changes about how the medical loss ratio is represented and how specific contractual requirements have to be stipulated with respect to medical loss ratio. In lieu of services, essentially is a mechanism by which states can elect to cover care for things that are designed to improve medical outcomes or reduce the expenditure on services. For managed care, our current managed care system does not include in lieu of services. And when you have in lieu of services, those have to be stipulated in our managed care contracts. But essentially, it's something that we don't currently operationalize, although we intend to be looking closely at this. What it does do in the rule is for those states that are employing in lieu of services, it maps additional requirements and standardization around how in lieu of services need to be managed by states. What I did do is just for those of you who are interested in, I included just a link that gives you an overview about what in lieu of services are and how they're managed. Next item is just on quality. So the department has a quality strategy specifically for, it's called our managed care quality strategy. I'm going to drop a link in that so this is a strategy that we update every 3 years. Our strategy is going to be coming due in the next several months. But with respect to the quality strategy, what it really does, the rule really enforces and encourages and requires that states engage in a much more robust stakeholder process related to our quality strategy. As some of you know, we've hired a quality consultant, which is separate from what Eric had mentioned related to our core set reporting and our on-point contractor. But specifically, we've hired a quality consultant to help us develop really from the ground up a quality strategy that encompasses all the various activities that we're engaged in with now in order to align all of our activities and really represent a 3 to 5 year strategy around quality for managed healthcare. Let's see, are there examples of state-directed payments here and how will they be impacted? Let's see. Are you asking, Andrew, if there's state-directed payments in Utah? Do I have that right?
Yeah, that's correct, Greg. When I was going through the rule when it came through the draft when it first came out, it was the first time I'd ever heard of state-directed payments. So I'm just curious if we use them, and if so, how are they going to be impacted?
So we have state-directed payments specifically for hospitals. And hospitals who participate in now we get complicated. So there's a hospital assessment that's done, and through that hospital assessment process, the state then makes directed payments through the managed care entities to hospitals that participate in the directed payments program. So that's one directed payment program that we have. We also have our ARPA directed payment program, and that program, for those of you who aren't familiar, is the 5% supplemental payments that the Oh, great. That the, let's see, now I'm totally blanking on the acronym.
You want help, Greg?
Yeah.
Okay. So that one in particular is a 5% supplemental payment increase to home and community-based providers and also behavioral health providers. That funding was provided through ARPA and is time limited and will eventually be expiring.
Right. So it sunsets March of next year, but it does provide supplemental payments to specific providers, categories of providers. And so that's a directed payment program. When we talk about directed payments, it's that these payments flow through our managed care entities. So there are providers that are getting these ARPA supplemental payments on the fee-for-service side, but those are made directly by the department to providers. But in this case, for services that are flowing through or paid by the managed care entities, we make essentially those funds pass through the managed care entities to the providers that are eligible to receive those. And then we also, yeah, go ahead, Andrew.
Oh, no, go ahead, Greg.
And then we also have one final directed, and these things take different flavors. We also have a directed payment program because in our Utah Medicaid integrated care plans, we have an essential provider fee schedule. And as a result of that, we have to have authority from CMS to essentially stipulate to the managed care entities that they're required to pay in a specific manner for specific services that the UMIC plans are responsible for oversight for and payment of.
That's really helpful to finally have a little bit of an understanding of what it means and the specific examples. And I'm just curious, the second part of the question, at this point, do you all think that the rule will have any impact on those or how they work?
So Greg, I'll take this one.
Okay.
So Andrew, we're mostly compliant with everything that was in the rule. There might be a few minor changes, but just the way we structured our directed payments are almost completely in alignment with the new rule as they've come out. So it'll be very little change to our directed payments programs.
Well, congratulations, Eric. That almost never happens. So
I know
well
it's wonderful when you're ahead of the curve on something like this.
Yeah. Thank you very much. I appreciate the answers.
You bet. So again, I had mentioned also we in managed care, we have an independent contractor called our External Quality Review Organization, and our external quality review just has some modifications to some of how they approach some of the work that they do. Another big change, not a change, but another big element to the rule is the establishment of we call it the MAC-QRS, which is Medicaid and CHIP Quality Rating System. And this would be the development and then the publishing and external facing information about health plan performance that would allow for enrollees, beneficiaries, individuals to evaluate plans against standard set of measures and criteria in order for them to be in a position to make choices and determinations about selecting health plans. So that's going to be a big piece of work that's coming down, and we're looking forward to doing that. And then the final piece is it just stipulates that a lot of what's being required in this rule also has to be modified for the CHIP plan or the CHIP program. And so some of these things, like for example, it does require that CHIP participate in CAPS, which it already does. And for those of you who aren't familiar with the OHCS website, that's a department website, but they do publish CAPS information. The link that I just put in is specific to CHIP, but you can a troll around in that website, and you can find quality related information reporting for HEDIS and CAPS for Medicaid as well. And you're able to evaluate, look at how the health plans perform on specific measures for both HEDIS and CAPS. One final thing that was presented earlier was just the timeline for some of these requirements. So I've just dropped a complimentary chart into the chat, which outlines the due dates for specific items that are identified in the rule. And then if you do go out to the summary that was just being presented, if you scroll down to the bottom of that, you're going to find some helpful links, both to the final rule itself, but also to this the applicability dates. Anyway, there's a lot of information in there. So this is a really high level overview, but there's enough to keep folks busy for several months if you start digging in. Any questions from the group? Okay.
Okay, thanks, Greg. Appreciate you presenting the next sequence of the massive bureaucracy that was dropped on the states and the public over the last few weeks. So lots to do and be working on implementing. So we appreciate the overview there. Okay. Next, we have the Notices Committee report from Daryl Hershaft has been asked to present that. Daryl, are you ready to give us an overview there?
Hello, can you hear me now?
Yes, we can.
Okay,
Thank you.
great. Yeah, thank you. So yes, a quick update from the Forms Committee, the group that looks at the correspondence that DWS and DHHS send out regarding Medicaid notices, Medicaid and CHIP notices. So in April, the committee finalized a survey of advocates of DWS and DHHS staff, including some Take Care Utah staff as well, basically asking, trying to identify what notices were the most confusing, and basically what to do about it. So the survey found, things that I don't think would be surprising, but that the forms tend to be a little complicated, too long, confusing, communicating complex information without using sort of, just conversational language. And just some lack of understanding about what the forms are saying. So the survey ranked the forms from most confusing to least. Confusing may be the wrong word, but that's what we're going with for now. And the 116M came up at the top. So over the course of the next several months, I believe the group will be looking at each of the forms, starting with the 116M, which is the Employer Health Insurance Information Form. And there will be a lot more after that. And then lastly, we also completed a Medicaid and CHIP review process flyer. So very abbreviated, sort of explanation of what a review is, how a review works, what to expect, that type of thing. We've gone through it a couple of times, and it is now back with DWS awaiting their feedback. And that's all that I have today. Thank you. Any questions, of course.
I know we have several other members on the MAC who participate in that committee. Any additional comments that anybody would like to add? And maybe what next steps are in trying to address some of these challenges?
I will add that one of the goals is to try to have a more visual depiction of information, something like a flow chart, something that's a little bit more, visually appealing rather than just having to read, through a page of text.
Okay, I don't know. Bureaucracy is pretty fun and intuitive for everybody, so it might be moving a little too far outside the box for the general public. Okay, thank you, Daryl. We appreciate your comments there. Okay, our next item on the agenda is committee member updates. So this is a time where we just open up the talk for members of the MAC committee to bring up issues that they've observed or are dealing with their groups they represent, whether provider or Medicaid member. So we'll just take any feedback or comments that you'd like to bring up now, and we'll open up the floor for that discussion. All right, Stephanie, go ahead.
Thanks, Michael. Yeah, I just thought I would share that there has been a issue with dental care that was raised at the St. George Medicaid member event, and I appreciate DHHS for meeting with individuals that are impacted. But it does seem like there are some dental care, like there's like maybe potentially not adequate access for dental care, and some issues around that. So I know a lot of people are working on that, but I am grateful for DHHS for putting together the information so that we can decide whether or not we advocate to the legislature next year to get some funding for that. But it did help. I just wanted to use that as also an opportunity to, there is a dental survey that the dental state director has put together and the Dental Health Coalition. And so I will just put it in the chat, but I am grateful for the work that they've done on this, and also like want to just encourage everybody to share it out. It's not just specifically to Medicaid beneficiaries. It's like statewide. Everybody should take it. But it will really help to make sure that we get a adequate look at how are we meeting the needs of people's dental and oral health. And so, and it's in multiple languages, and they've worked really hard on making sure it's accessible. So I'll put it in the chat and just wanted to amplify that as well.
Okay, thank you, Stephanie. Stacy, go ahead.
Hi, thank you, Stephanie. I just wanted to, I'm Dr. Stacy Swilling. I am the state dental director, and I met with Stephanie last week after that Medicaid meeting. And I just wanted to give you just a little bit of background that, and we are developing the state oral health improvement plan. And it was very important to me that I hear from consumers of oral health care, in all different situations, and it is available in 9 different languages. So I really would appreciate spreading the word, and so we can just hear about how people are able or are not able to access care to influence our future direction of the oral health program. So thank you.
Do you have an avenue through which you would prefer to receive feedback? Like is there a website or an email address where people could, that we could distribute to the constituencies we represent and make sure we help get
I can drop my email address in the chat, and you can reach out to me as you'd like to.
All right. Thank you. Appreciate your participation there. Colleen, yes?
I would love to help participate in that as well. I have not a new adult, you know what I mean? She'll be 26 this summer. That is our consumer. And yeah, we're always being steered in different directions as far as, you know, what her plans look like on paper. Yeah, she has supposed dental benefits, but it's very difficult to access those. So until this summer, we've been still using private services a lot, or her dad's insurance a lot, and always kind of being steered to, you know, this one Medicaid clinic that we're not trying to avoid for any other, for specific reasons. But everything always looks great on paper. Yes, this is provided. This is provided. Even down to her home and community-based services. We won the golden ticket. You betcha. But from the story that comes from, we have to remember those, you know, we lost 5 of 6 of those kids to not paying attention, to taking advantage of the system, to not understanding the rules, to just not having the supports that they needed to make it to the end of getting the actual grand prize. She's a fully funded individual on DSPD and maybe receives 4 hours of services a week because there's not direct care providers that can supply the supports that she needs. And so again, I would love to participate in any of those, again, committees and programs that are helping to speak to that path for direct care providers, whether it's rates or you know, reaching out to people who are willing to work in that industry, to creating career paths for individuals that are working in that industry. But we're seeing that a lot with these families, especially as they are coming off of the wait list, or as there are more availabilities in these programs. You get so excited, and then they're so disappointed that there isn't access to actually utilize the funds that they've been dreaming of for 10, 15 years on a waiting list. So we're having to coach a lot of families through that disappointment and support them through that. So that's something that we're really struggling with in our community, and that that part of the disability community for sure.
Okay, that's an excellent point. So even in addition to the dental services you're talking about just core HCBS support services for people coming off the waiver.
Lack of support services, not always poor services. We have, you know, the staff we can find are very great and very caring. It's just hard to find them in the first place.
All right, well, that sounds like a good topic for us to maybe put on our August agenda and see if we can raise some visibility to that as a broader issue, and see if we can raise some awareness and see what can be improved. So thank you for bringing that up as well. Okay, other topics?
I will say another one if nobody else is going to jump in, but also appreciate what you said, Kayleen, because I think that's really important. I did want to just say, because I feel like I was a little aggressive earlier, that I do want to just say that, like, one of the places I go to help a lot of members, I went there a few weeks ago, and usually I'm really overwhelmed when I leave by how many people are frustrated. And like 4 people that night just like thanked me and were just so excited because the people that I had connected them to on the Medicaid policy team had been so incredibly helpful and immediately resolved their issues. And I did want to just say that I am really grateful for that. And then I did want to just touch back on another thing that we've talked about in previous months, which I do think there is just some issues with some unpaid bills happening. And I realize there might be a lot of different causes, but another one was just brought to me this week, and I'll send an email to all of you that I contact about this, but like there are just some issues, and I realize there might be a lot of different causes. I do hope that, like, I don't know, it would be interesting to know like what type of conversations between all of the different stakeholders involved, the plans, the hospitals, Medicaid, PRISM, DWS, I don't know. There's just a variety, I think, of issues, but I think just like knowing how we're dealing with that, especially like looking backwards. If there's any way to like try and see like how to make sure that I get really worried whenever people are actually paying the bills that I don't think that they should be paying, because I don't, I mean, there are times where they're paying that instead of their rent, which makes me incredibly nervous. And so I just want to just say that that still does seem to be something I'm hearing about, and I'm trying to just like connect people in the right, like the best way. But I do think it's an issue, and I don't know. I feel like maybe that's just something that we can get an update on in the future, as far as like what is going on there and what is actually being done to like mitigate that, and deal with it from maybe a more like not just one person at a time situation, unless that's the only way that it can be handled, which means we need like way back, like a lot of community organizations maybe need to be trained on like how to do outreach on this, because if it's happening frequently, then we want to make sure that the public beneficiaries know that they should not be paying, that they should be making sure that the Medicaid bills are paid by their plan or Medicaid. So anyway, I just wanted to raise that again.
Yep, that's a good one. Thank you for the ongoing status on that. And just so the rest of the MAC and the public know, because of the challenges with the PRISM system, sometimes retroactively disenrolling individuals who are enrolled in Medicaid or other eligibility issues, the information that needs to go to the health plans to show the member is enrolled in the health plan or even eligible for Medicaid isn't making it to the health plans or to the providers on the eligibility file. So the Medicaid member is not showing as being eligible, and then is frequently receiving a bill for services from the providers. And so we do want to raise awareness with Medicaid members, trying to navigate the multiple challenges of core eligibility, enrollment in a managed care plan, or for the providers to see the eligibility and enrollment online, so that the member doesn't get balance bill and get left feeling like they owe something, especially if they know for sure they're enrolled in Medicaid. So we'll add that to our August agenda as well. So thank you, Stephanie, for bringing that up again. Okay, let's go to Sharon, who I believe has been working diligently to tally up the votes and see what the results are for the prioritization from the public meeting.
Yes, thanks, Michael. I did tally the votes that have been received, and I have them here. I will read them off. I will also send this PDF out to you all probably tomorrow morning. And if there are any committee members that vote after this meeting, I do still add those and send this to the DHHS leadership so that they're aware for the, budgetary impacts and their proposed budget that goes to the governor later this year. So with that, I will read through this just so those who are on the phone can hear as well. So on the screen, the members voted 1 through 27, 1 being their highest priority, 27 being the lowest priority. So when you see the total score here, the total score, low score means highest priority across those who voted. And then you'll see the results 1 through 27. So coming in at number 1 is the mental health system and Medicaid with a total score of 71. For number 2 is the home health rates with a total score of 90. Number 3 is the HCBS waiver rates with a total score of 98. Number 4 is the rate parity within the DSPD community supports waiver with a score of 99. Number 5 is the new choices waiver increase with a total score of 109. Number 6 is the community health workers reimbursement with a total score of 112. Number 7 is the developmental disabilities system and Medicaid with a total score of 113. Number 8 is the Medicaid waiver reimbursement with a total score of 120. Number 9 is the infant and early childhood mental health service reimbursement increases with a total score of 122. Number 10 is the psychiatric collaborative care services with a score of 124. Number 11 is the peer support services rate increase with a score of 134. Number 12 is the private duty nursing requests with a score of 146. Number 13 is the ePass case management rates with a score of 150. Number 14 is the lactation consulting services with a score of 164. And then we've got number 15 is the PACE with a score of 178. Number 16 is the prenatal testing with a score of 185. Number 17 is the neurosurgical application of laser and interstitial thermal therapy with a score of 187. Number 18 is the medical management of chronic obesity and budget considerations. Number 19 is the mobile radiology services with a score of 200. Number 20 is the bone growth stimulators with a score of 210. And then there was a tie with a score of 215 for therapeutic footwear for diabetics and Camp K services. So then number 22 is the free Spira treatment for panic disorder and post-traumatic stress disorder with a score of 225. Number 23 is the Tula system with a score of 232. Number 24 is the expanding access for skin substitutes with a score of 253. Number 25 is the ID Gentex with a score of 288. And 26 is the Canvas DX with a score of 297. And that is all of the priority rankings for the fiscal year 2026 budget recommendations.
All right. Thank you, Sharon. We have a question from Monica Frederick. Monica?
Hi, thank you so much. I just, this might be a stupid question, but number 1 means that's a top priority, even though the total score is lowest. Is that correct?
Yes, that's correct. Based on the way the voting is handled. So that's right.
Great. Thank you so much.
Okay, thank you, Sharon, for putting that together. Just a quick question for those who haven't voted. What is your deadline for MAC members to submit their votes? Is it today?
Yeah, so in the past, we have accepted, like a week out. Just, there's vacations and things like that happening. I have emailed everyone who has not voted. Most of those are not on the call today. So I'm assuming, there's vacations and other priorities that have come up. So I give them about a week or so. Like I said, I do still include their votes. And if there's changes in the results, I do, pass that along to leadership. So, if I can have all the committee members vote within this next week, that would be ideal.
Okay, very good. Thank you for pulling that together for us and giving us the summary. So that concludes our agenda today. We've run over by a few minutes, but I'll entertain a motion to adjourn now.
I'll make a motion to adjourn.
Okay, thank you, Rachel. Second?
I'll second it.
Okay.
This is Kim Dancy.
Okay. All right, and unless anyone opposes that in the next 3 seconds, we're going to be considered adjourned. Okay, thank you for the time today and all the presentations from the department and the feedback from the many members of the committee who've shared personal experiences that help edify our discussion. And we'll see you soon. Thanks.
The program, and actually they have